I'm now going to bring in Dean Russell, then Taiwo, James Davis and Sarah Owen. I want to move on to the second panel around 10:30, so I'll be grateful if you could be fairly brief. Start with Dean.
Thank you, Chair. My question is a simple one, hopefully. We've heard a little bit about the processes, but I just want to understand what the methodology is for a lifetime plan for autistic people. My understanding is that there will be certain triggers and symptoms and issues that will happen on a whole range of things. But what it feels like from what I hear is that the families don't necessarily have as much of a say, the individual doesn't have as much of a say. And I just want to understand whether there are such a thing, or is such a thing as a lifetime plan to say, well, if this happens and I do have to go to inpatient care, how long I will get to choose before I come out, how long the family get to choose before I come out, and what that process is. Does that exist?
If you want me to come back on that one, it exists in a patchy way, so it's not good enough. We have improved the immediate post-diagnostic support for autistic people is better than it was 10 years ago, but the long-term post-diagnostic support is still extremely limited. There are things like hospital passports and advanced directives that can be done. As Ken has alluded to, in learning disabilities, they've got intensive support teams. In mental health, we have intensive home treatment teams and crisis teams, and we're skilling them up to work with autistic people who've got mental health problems. We are care planning can be used. So the tools in theory exist. It's actually getting to the point where the plan is meaningful because you can actually access something when you need it in a timely manner. And that's the critical bit.
And sorry to interrupt, because I'm conscious of time. I'll be very brief. So would you say then having what I would call a compassionate lifetime care plan would make sense? So from the point that somebody is diagnosed to be an autistic person, that there's a very clear pathway, there's an agreement with families about how their care should be looked at and what inpatient care should be considered. And that's something that sticks with them. Perhaps it's a technology solution throughout their lifetime. Would that be something that would help the process?
So what we say is that there should be a strengths, needs and aspirations formulation as part of the assessment. So we want to move away from impairment-based language to a strengths-based language. We want to look at people's strengths, their needs, but also what they want to achieve in life and how you're going to help them achieve that. And so that should be set out at the beginning. And over time, people's choices will vary, people's life experiences will vary. So what we're saying is they should have access to reviews through their lifetime when they need them, because what you thought you wanted as a teenager may not be what you want as a 20-year-old or a 30-year-old. So there should be opportunity for reviewing that. But yes, there should be that sort of formulation. There should be that document that you own. It's your own assessment. You've got it, and you can share it with anyone that you want to. And it should then be supplemented as appropriate, depending what your needs and aspirations are, with things like hospital passports and other types of tools that can be used for specific circumstances, such as if you reach a crisis point.
Thank you. I think if anything like that does come in, I think it'd be really powerful to have compassion at the heart of it and a say in everything. I'll finish there, Chair, because I'm conscious of the other colleagues want to come in. Thank you.